Hi guys, Chris Slenderman here from StrengthPhysio.com, and in today's video we're going to go through a presentation on ACL injuries and rehabilitation. Stay tuned. So the aims of today's presentation is to go through the pathology of ACL injuries, look at clinical presentation of ACL injuries, look at conservative or surgical management, looking at problems after ACL injury, rehabilitation protocol for the ACL post-surgery patient, and videos and exercises for each phase of the rehab, and then research around ACL tears and rehabilitation. So, ACL injuries. ACL is a primary stabiliser for resisting anterior translation of the femur on the tibia and controls hyperextension of the knee. It's a secondary stabiliser of internal and external rotation, as well as varus and valgus stress. It's injured mainly through a valgus force applied to a flexed, laterally rotated knee with foot planted on the floor, or hyperextension with a bit of medial rotation. Less commonly, it's caused or injured by hyperflexion or a direct valgus force. Your classic thing obviously is in football or sports where you get that classic picture of the person on the one leg, planted, and they're twisting. It's that twisting type injury that you get. So there's 100,000 ACL repairs annually in the US, and between 2.4 to 9.7, depending on where you read, times higher in the female athlete, and we're going to go through that a little bit later. It's often combined with a medial meniscus and MCL injury, and that's what people refer to commonly as the terrible triad. So, in terms of clinical presentation, subjectively what you're going to find is that the mechanism of injury is a landing and twisting injury. Usually they'll hear an audible pop or crack or feeling of something going out and back in again at the time of the injury. And generally it's associated with severe pain straight after the injury and often unable to continue the activity or weight bear on that leg. Swelling is often immediate because of the hemarthrosis within the joint, and this causes people to again not be able to continue with their sport. And then often this feeling of instability and giving way, particularly when turning, and this is especially true for people who are a little bit later down the line, so maybe you see them 2 to 3 weeks after the injury rather than seeing them at the exact time of the injury or just after the injury, and when the swelling etc might be too much to actually feel that instability because they're not weight bearing. Objectively, obviously you're going to see a restricted range of movement, particularly into extension initially, a widespread mild tenderness over the joint, lateral joint line tenderness due to the stretch of the lateral joint capsule when subluxing, and you also get medial joint line tenderness if the meniscal's been injured. You will often find it just extremely painful, quite hard to assess initially because of the amount of swelling etc that's in the joint. You're going to find a positive Lachman's, positive pivot shift. If the MCL and ITB are intact, can be difficult to perform often due to anxiety and pain in the patient. You can also do an anterior draw test. This is the least specific of the tests, and also a positive Leyli's sign, as well. All these tests can be looked up online, and you can see videos of what those tests are. We're not going to go through exactly what those tests are for each thing. Just a bit of continuation. So X-ray of the knee should be performed if you're fearing an ACL, as it may present with an avulsion of the ligament from the tibia, or a Sagon fracture, which is an anterior lateral capsular avulsion at the lateral margin of the tibial plateau. But generally MRI is the imaging of choice for diagnosing ACL injuries. What you'll also find with a lot of patients on MRI is that bone bruising is very common, over 80%, usually on the lateral femoral condyle, and that's caused by impaction of the lateral tibial plateau and the lateral femoral condyle during displacement of the joint during the time of injury. There are question marks over whether this predisposes people to having arthritis in the future in terms of an ACL, not the bone bruising. Probably best to reduce pounding activities for 3 months in the cases where bone bruising is present. Again, we'll talk a little bit more about arthritis, etc. going forwards into the presentation. So, conservative or surgical treatment. Obviously this is going to depend on age. It's going to depend on the degree of instability and associated abnormalities. whether the patient performs pivoting sports, and their occupation and social factors. So you need to take everything into account. It's not going to be a yes or no. Often it's going to be looking at their whole clinical picture. Pivot shift is in the unconscious patient can often give a sign of significant instability, and if that is the case, then often the surgeons will recommend surgical management. And as I was saying earlier, so there's no evidence that surgery reduces OA risk in patients at the moment. And also, when having surgery, the knee should have little to no swelling, near full range of movement and normal gait to get the best results. A lot of people, I think when you have an injury to the knee, your risk of OA goes up, and your risk of injury goes up of that knee going forwards. Whether there's any reduced OA risk, there's no evidence for that at the moment. So it's really going to be based more on your sport, the lack of degree of instability, etc. Essentially, are you functional or not? If you're not functional and you're really struggling, then you're probably going to need to have it surgically repaired. So a few problems can result post-surgery. So you can have patellofemoral joint pain, low back pain can be common with these sorts of injuries, stiffness around surrounding joints, and just arthrofibrosis, so stiffness of the joint, can be another problem that can occur after surgery. Outcomes though are relatively good, so 65 to 88% return to sport and only a 3 to 6% graft failure. There are increased risk of other injuries and of injuries to the other leg, and this is most likely 12 months after surgery, so that's something to definitely consider. So as we talked about earlier, women have a higher incidence, so why is this? And again, there's no really concrete evidence for this. The suggestions that people give are anatomical differences, so smaller size and different shape of the intercondylar notch, greater Q angle and a greater ligament laxity. Hormonal influences, people sometimes will quote, but there's unlikely to be a direct relationship here. And neuromuscular factors, so women are more quad dominant when stabilising the knee, and this can increase incidence. But the biggest thing that I found, and when you look at the evidence, what you will find is that it's usually a combined factor. Like most things in life, it's more to do with a combination of these things, which is more predictive of injury. So if you're a female, you've got a decreased intercondylar notch width, you've got increased body mass and generalised joint laxity, and that's going to show strong predictors of having these sorts of injuries. One or other of these is not necessarily going to be a causative factor. So if we go on to our protocol now, so you've decided to have surgery, or a patient's decided to have surgery, what sorts of things are you going to be thinking about? So obviously in your preoperative phase, you want to minimise the swelling, you want to minimise inflammation and pain, normalise your range of movement, get some strength back in the leg, try and restore full symmetrical gait, and even work on some plyometrics if you can beforehand. So obviously the treatments you can use for this are using outcome measures, using Game Readies or cryotherapy. Game Ready is just a machine that does compression and ice. You can use obviously walking aids, passive mobs, active knee movements, quad activation exercises, normalising knee mechanics and proprioception, and then there's just some exercises down the outside that we're suggesting that you could do. Obviously your normal range of movement exercises, closed kinetic chain exercises with your lunges, squats, step-ups, etc. as the patient progresses. So all those things can be used, and in another video going forward, what I'm going to do is actually do an example of all these exercises on video so that you can see that. But just for the scope of this presentation, we're just going to go through the actual protocol itself. So then we've got phase 1 post-op. So you've had the operation, phase 1 post-op, which is usually about 0 to 2 weeks post-op. It's the hugely important thing is reducing swelling, and restoring full extension is key. So we want to get that quad back as quickly as possible. I myself have had an ACL op and had what's called a cyclops lesion after having that, which means that I couldn't get full extension because of a bit of a scar tissue that developed in my intercondylar notch. And that meant that I couldn't get knee extension, couldn't get my quad going, and therefore 8 months later I was still really struggling, had to have another operation to remove that Cyclops lesion, and after that it was really good to go, and my rehab massively got better. So I think the big thing or big takeaway is a full extension is absolutely key. We want to have active knee flexion of about 90 degrees, but we're not massively worried about this. We just want to progress that as we can, and we're trying to restore patellar mobility, get a bit of static quads and straight leg raise, 3x15 with no lag being a good just objective mark to have, and normal gait with no limp and without crutches if possible after a couple of weeks. Again, all these phases are going to be fluid. You're going to have some people that fit this and do really well, and some people that take a bit longer, and that's absolutely fine. So in this stage, you obviously got your game ready, your cryotherapy. You can use electrical stimulation quite nicely in this phase, so that you can get the quads going and without too much, without being too difficult for the patient. Passive overpressure MOBs, so getting some passive overpressure of extension. Obviously with flexion, we don't really want to push that. We just want to be quite gentle at this stage. Doing lots of quad setting, weight bearing as tolerated can be really helpful as well. So the sorts of exercises I love this phase are prone hangs, so that you're lying essentially on your front with your knee over the edge, and you're going into that extended position. So actually getting them to spend periods of time in this position so that we can really work on that extension, I think, is key. We want to basically work on obviously your active range of movement, not forcing, so just as tolerated, not forcing it into that. Working on your terminal knee extension in standing with a band is really, really nice as well. It just starts to get A, the weight bearing, and B, the extension in that weight bearing position. And also just mini squats, so mini squats being literally 10 to 15 degrees, so you really just, it's more that athletic position that you're finding, and then weight shifting from side to side, so just getting used to shifting the weight onto that side. And also quite useful to start some hip exercises, non-weight bearing and weight bearing, so doing things like your banded clams, side planks, that sort of stuff can be really, really effective. And also get some non-effective proprioception work going on the other leg, so doing your sprinter's exercise, so you're getting that running position, but you're not putting any weight on the actual affected leg, or you're not going into that affected leg, because again that's a little bit difficult at that stage. Then we're going to go on to our second phase, which is usually our 2 to 5 week type time frame. We're looking for what's called a quiet knee, so essentially obviously a knee that is reduced swelling, it's not hot, it's not quiet, just meaning it's not giving you many symptoms. Want to try to get full active hyperextension, passive flexion to about 130, normal gait, a single leg balance of 30 seconds with co-contraction, which is getting your hamstrings, glutes and quads contracting at the same time in a standing position. Slight knee bend. Small step up, 3x12 with no pain, and 20 minutes of cycling pain free. So I like to have a few of those just objective markers in each phase, because it gives the patient something to work towards, and it also gives you something that you're looking at and seeing whether you're reaching that. So again, obviously lots of game ready cryo stuff, and Compex is useful as well. Passive MOBs, your activation exercises, and progressing obviously to your full weight bearing exercises. Soft tissue can be useful sometimes in this phase, but obviously exercise is the key. Proprioception are also really important, and want to introduce weights or strength resistance exercise, so that for some people that might be weights, for some people not, by 4 to 6 weeks, obviously depending on their current rep max, and that's going to depend from person to person. So again, similar to last time really. So again, with the active range of movement now is going to be as tolerated, but trying to improve that. The different things that we can add in now, things like multi-angle isometrics for the hamstrings, small box step-ups is another thing that's good to add in now, and then one leg balancing, so proprioception on that side, rowing but just within your range of movement, and stationary cycling with a really low resistance, and also getting into the pool once the wounds are healed is really effective as well. Treadmill walking can be useful, and hammies in prone and standing with no weight, so standing hammy exercises with no weight, standing hip exercises, that sort of stuff can be really good. Proprioception walk series and lunge series can be quite nice. and again, that's something I'll look at in the video if you don't know how to do that stuff in another following video in terms of exactly what the exercises are. So we've got our third phase, which is 5 to 12 weeks. Weeks 8 to 12, because of the ligamentization process, we don't want to change in the program particularly. We want to kind of stay with the same level, but still working on trying to improve, but just not massively changing the load or volume in that stage. Again, in terms of what we're looking for and our goals, we want to try and get full active and passive range of movement if we can by this point. Or as normal as possible, and definitely normal gait. Single leg balance on BOSU with co-contraction now of 60 seconds, and a stiff leg deadlift 8 rep max of 60% of body weight, or a prone leg curl if deadlifts are difficult for the person, and a single leg press of 70% of body weight as an 8 rep max. So again, just gives you some strength markers. These aren't evidence based in terms of those specific amounts, but they're I think they're useful to just try and get someone back to a good level of strength overall. Obviously at this stage we're going down much more the route of starting to get walking on the treadmill. We're working on more open chain exercises, we're working short lever quad exercises. And again, from an exercise perspective, we're starting to add in more of our step ups, our lunges, bridging, rowing, cycling, cross trainer, pull, all those sorts of things, prone hamstring curls, stiff leg deadlifts, and very much proprioception at this stage as well. We also want to include the core exercises all the way along, which is going to involve non-weight bearing planks, etc., that you can work, which can be really helpful. Also, single leg squat to 90 degrees at this level would be good, kind of 4 times 12, just body weight, so just sitting down and standing up, getting that sort of stuff going. And small foot plyos with no reaction. So at 12 weeks we want to aim to be straight line running, so we do need to start doing some small foot plyos at this stage if we can, as long as there's no reaction to that afterwards. So then we've got our third phase, which is 13 to 22 weeks. Again, all this now is just continuation really. We're starting from 12 weeks to do straight line running up to about 75% of our speed. We want to have good hamstring strength now, so stiff leg deadlift 80%, body weight for 6 rep max, or alternatives. So for example, your lying leg curl or leg curl, single leg press of 1 times body weight, so body weight essentially for 6 reps. And single leg hop, left versus right within 10% if possible, T-test within 20%. And again, you can look those up, but they're good markers to have at this stage. So again, from a treatment point of view, it's very much exercise now. We're really working on strengthening really, and working on our plyometrics, working on our proprioception, all similar things to what we've been doing. And again, in later videos I'll go through those specific exercises that can be quite good and nice. And then we've got our return to sport phase basically. So again, we want to have a concentric to eccentric hamstrings ratio of about 0.9, left versus right. Stiff leg deadlift now 100% of body weight for 6 reps. Single leg press 120% body weight for 6 reps. Crossover hop, left versus right within 10%. T-test within 10%. Sport specificity tests, so just getting the person obviously back into their sport, and also doing things in your rehab that maybe replicate their sport. And then also a triple hop test within 10% as well. So now again, very much sport specific training, weighted exercises from a strength perspective, doing your lunges, squats, step ups, those sorts of exercises, hamstring exercises. At this stage, you start doing your Nordic extensions, can be really useful for the hamstring. Lots of proprioception drills and neuromuscular training as well at this stage, which again, proprioception exercises as we've gone along, essentially a neuromuscular training exercises. And then getting in your advanced turning and sport specific drills at this stage is really useful as well. So you want to be, have them turning, twisting, doing things that are similar to the mechanism of injury to try to build up their confidence. And again, that's something we'll talk about in a second. So research wise, I just wanted to go through a few little bits of research that I think is quite interesting and quite useful with ACL. So in 2015, Bien did some research that showed that strength training in isolation doesn't guarantee improvements in hip and knee kinematics. and that improved lower extremity strength does not guarantee improved landing technique. And this suggests that while deficits in strength and activation ratios are serious factors that contribute to re-injury risk and suboptimal performance, there are likely other contributing factors that may not be remediated with strength training alone. So they also talked about readiness to get back to sport in this study, and it's a really interesting one, so go and have a look. They talked about the confidence of the player getting back into their sport, and I think that's why, as I was just saying a second ago, doing drills in your training that actually can work on things they're fearful of, I think is a really, really important factor. We need to make sure that when they get back to their sport, they are doing things without thinking about it, without worrying about it. That's a really key factor. So I think if you can do that, that would be really beneficial to their rehab, and the research is going to suggest that, or is suggesting that as well. So another one by Froebel in 2010 that showed that in young active adults with acute ACL tears, a strategy of rehabilitation plus early ACL reconstruction was not superior to a strategy of rehabilitation plus optional delayed ACL reconstruction. The latter strategy substantially reduced the frequency of surgical reconstruction. So just quite an interesting one there about, our perception of whether people should have an ACL operation, and the fact that they did a follow-up with these patients at 2 years, and they didn't find a huge amount of difference in patients that had early reconstructions, late reconstructions, and then no reconstructions at all in terms of their function, and it actually reduced with the patients they did with a late rehab, it reduced their amount of surgery by 61%. So it's quite interesting when you look at studies that obviously 2 years is a long time, and so whether it'd be interesting to look at that study in a bit more detail and have a look whether people got back to sport as quickly. So obviously they're at 2 years they had a similar outcome measure, but what about when they were a year? Were they back into their sport, or were the people that were surgically repaired better earlier on? And obviously that's going to be a factor, but it's an interesting concept to think about, I think, with ACL repair. And then Shah-Hill in 2013 in a study showed that the 6 weeks progressive prehabilitation program for subjects undergoing ACL led to improved knee function based on the single-legged hop test and self-reported assessment using the modified Cincinnati score, and these effects were sustained at 12 weeks post-op. So a little bit of research there which just backs up doing a prehabilitation program, showing that can be effective, which I think is important to tell patients that it is important to do, and here's the research that backs that up. And then also just a nice one in JOSP in 2014, which was based on a Meyer et al. Study, which showed that 3 tests are quite useful for using during more advanced recovery phases after surgery to help basically ensure that athletes' exercise program is successful in returning the injured leg to the level of the uninjured leg. And back to sport, basically. So this is very much about back to sport, and the researchers suggested that the surgically repaired leg should perform at 90%, as well as the uninjured leg, before you return to sport, in the single leg hop, the triple hop, and the crossover hop test. So triple hop is just 3 hops in a row, and crossover hop test is 3 hops in a row but over a line centrally, which again I'll go through on another video. And that just shows you, and you basically measure distance, and then you can have a look and you can see what you compare and contrast the injured leg to the non-injured leg. It should be about 90% before you get back into sport. So that just gives you a guideline of is this person ready to go back to sport, along with other things that we've discussed in terms of readiness, how ready they feel psychologically, whether they feel ready. So they're just some references from those research studies, so you can always go over and have a quick look at those. So hopefully today's quick presentation, I've gone through things fairly quickly just because obviously I don't want to spend massive amounts of time on anything, but if you've got any questions about anything, then please give me a shout. As I said before, I'm going to do a video that is more a demonstration video of a lot of exercises I like to use in ACL, so make sure you check that out. Hopefully you've really enjoyed the presentation, and I will talk to you all soon.